Good morning. I hope you've not had enough of endemic infections because there's another important one we have to discuss, and this is on hepatitis B. My disclosure, I am not a hepatologist, but because Dr. Masigan is my BFF, I couldn't say no to her, and so I did my assignment. So I made it very simple, and I'm going to hopefully be able to address the frequently asked questions, particularly on disease burden, transmission, clinical spectrum, diagnosis, and a lot of questions on prevention. If you notice, I deliberately not include management because I think that belongs to the gastroenterologists. Are there around here? Are there gastroenterologists around? Okay, first question. So stir up your interest. Is hepatitis B highly endemic in the Philippines? Aba, alam yung sagot. Anyway, let's look at the disease burden in the world. More than 2 billion people are supposedly infected worldwide. And then that translates to like 360 million people chronically infected. And most of these diseases supposedly are in the Asia-Pacific region. WHO determines the level of endemicity based on the prevalence of chronic hepatitis B surface antigen carriage. So a country is said to be highly endemic if the prevalence of HBs antigen carriage among adults is 8%, take note, 8% or more. It's a country is said to be, the endemicity is said to be intermediate if the prevalence is 2% to 7%, and the endemicity is said to be low if the HBs antigen prevalence is less than 2%. So what is data here in the Philippines? So the most recent national study on chronic hepatitis B prevalence among Filipino adults, 20 years and older, estimated HBs antigen seroprevalence to be 16.7%, corresponding to an estimated 7.3 million cases of chronic hepatitis B among adults. Take note that though this is not, the study I understand was done in 2003, way back in 2003, where a birth dose was not yet routinely being given. However, it was published just recently in 2013. But I understand this is the study that indeed documented that hepatitis B the Philippines is highly endemic for hepatitis B. So next question, how is hepatitis B virus transmitted? So primary sources of hepatitis B infection, the most common mode, take note, the most common mode of spread in highly endemic areas, like here in the Philippines, will be what? Perinatal exposure from infected mothers at birth. And WHO and DOH estimate like 10% HBs antigen positivity among Filipino women of childbearing age. And this is very important because the risk of vertical transmission without prophylaxis is very high. It's like 70% to 90% vertical transmission in a mom who is both HBs antigen and HBe antigen positive. And the vertical transmission, while the vertical transmission is like 10 to 40% if the mother is HBe antigen negative. Another important source of the virus in early childhood in endemic countries will be horizontal transmission, person to person, and this will be through inadvertent percutaneous or mucosal contact with blood or infectious body fluids within the household. Okay, like sharing of personal items, what's mentioned it would be sharing of toothbrushes or razors, and exposures to cuts, wounds or bites. And I found this very important because a child can even get hepatitis B, when in contact with HBs antigen contaminated surfaces, because the hepatitis B virus supposedly survive very long, is capable of surviving very long in the environment for like 7 days or longer, even in the absence of blood. So that in the Western Pacific region, most cases of chronic hepatitis B results from vertical transmission at birth or horizontal transmission in children under the age of 5. Okay, but other important sources will be high risk sexual activity, having multiple sex partners, and male having sex with males, and also unsafe injection practices, use of contaminated needles, syringes, sharps. Be careful for those of you who plan to have a tattoo. There's a local data that chronic hepatitis B is rather common among adult Filipinos who have undergone tattooing. Oh, last night, most of us PIDSP members had foot spa and free pedicure. But just take note, that's the way that one can get hepatitis B. Okay, so among adolescents, a very important way to get hepatitis will be through high-risk sexual activity and unsafe injection practices or needle stick injuries. But hepatitis B is not spread through food or water, sharing eating utensils, breastfeeding, hugging, kissing, hand-holding, coughing, or even sneezing. So what's the clinical spectrum of hepatitis B? So take note that acute infection, the likelihood of symptoms is age-dependent. So that most of the children who have acute infection are expected to be asymptomatic. This is compared to older children and adolescents. And here will be the spectrum of signs and symptoms. They can have a subacute illness with non-specific signs and symptoms. Of course, it can be one of clinical hepatitis. Fulminance can happen, but again, the risk of fulminance is more among adults, but take note, mortality is very high. And as we teach to our students, it's with hepatitis B that extrahepatic manifestations can be expected. I remember we came across one in the Children's Hospital where the patient initially presented as glomerulonephritis. Okay, but most acute infections in adults will result in complete recovery. A big problem will be chronic infection. And as you see here, the development of chronic infections is inversely related to age, so that 90%, up to 90% of infants infected perinatally, that means those who get it from their mom at birth or in the first year of life, will develop chronic hepatitis B. Between 25 to 50% of those who get it in early childhood, who get infected in early childhood, will be at risk of chronic infection. And this is in contrast to older children, including adults, where the risk of chronic infection is 5 to 10%. Okay, so the presence of immunosuppression or chronic illness at infection also increase the risk of chronic infection, chronic diseases. No, immunosuppression or those with patients with underlying chronic illnesses at infection will definitely increase the risk of chronic hepatitis B infection. Unfortunately, most of young children who are chronically infected will be asymptomatic and even unrecognized until a complication like chronic liver disease, cirrhosis, or hepatoma will develop in mid-adulthood. And without monitoring and treatment, 25% of chronically infected infants and children will die prematurely from hepatocellular carcinoma, if not cirrhosis. And I found that there's so much data on chronic hepatitis B among adults in the Philippines, including this one very recently available in the internet. And according to this data, in the Philippines, there is higher prevalence of chronic hepatitis B among patients with chronic liver disease, that's 45.7%, hepatocellular carcinoma, 70 to 74.8%, and cirrhosis, 58.2%. So So how is the diagnosis of hepatitis B established? So clinically, hepatitis B will be difficult, or you won't be able to differentiate hepatitis B from hepatitis caused by other viruses. And therefore, you will have to request for, do serology. So this is what happens in a patient who has acute hepatitis B infection with recovery. So here, So acute hepatitis B is characterized by the presence of HBs antigen, okay, together with IgM to your anti-HBC. Okay, and during the initial highly replicative phase, the patient likewise may be HBe antigen. Okay, but when the patient recovers, anti-HBs will appear, followed by clearance of your HBs antigen. Take note that during the window, okay, when your HBs antigen has disappeared, the IgM anti-HBC is the one that may be present, no, that will be indicative of an acute infection. So this is the picture of one who is susceptible. This is the picture of one who has an acute infection. So take note, the patient will be positive for both HBs antigen and IgM anti-HBC and the total anti-HBC. But I said in the window period, it may just be IgM anti-HBC that will be positive. So this is the picture of one who is immune from infection. So what will the patient have? Patient will have both antibody to the hepatitis B core, and very important will be the presence of anti-HBs. Likewise, this will be the picture of one who is immune following vaccination, where, you hope to see anti-HBs. But this is the picture, this is what happens when a patient who perhaps had an acute infection goes on to have chronic infection. So, what is the one with a chronic infection with a persistent HBs antigen, more than 6 months, together with anti-HBC. But we said IgM, anti-HBC will disappear, okay? And a patient who is chronically infected may be HBe antigen, or maybe the HBe antigen may be positive or not. So this is the picture. This is the picture of a patient with a chronic infection where HBs antigen will be persistently positive for more than 6 months together with anti-HBC, but there will be no anti-HBs. So these are all the important serologic markers. Take note, the presence of HB antigen will be indicative of high degree of infectivity, while if the patient develops anti-HBe, that would mean lower risk of infectivity. There's another one that we perhaps are not all familiar with, which is HBV DNA, and I understand it's locally available. It's just very expensive. I think it costs how much? 5,000. But this is also a marker of viral replication and correlates with infectivity. And I understand this is what gastroenterologists request for to assess, monitor, okay, patients, assess and monitor treatment for those who are chronically infected. So how is hepatitis B prevented? The best approach, as we all know, is vaccination. The primary goal is which is to eliminate transmission of hepatitis B, thereby decreasing the rates of chronic hepatitis B and hepatitis B-related cirrhosis and hepatocellular carcinoma. So, since the availability of the vaccine worldwide in 1982, recommendations for hepatitis B vaccination have evolved into a comprehensive strategy to eliminate hepatitis B transmission. And ideally, the program should include, and the important four components include universal immunization of infants at birth, routine screening of all pregnant women, and appropriate immunoprophylaxis of infants born to HBs antigen positive women and infants born to women with unknown HBs antigen status. This should also include catch-up immunization for unvaccinated children and adolescents, and immunization of previously unimmunized high-risk adults. So, But WHO realizes that antenatal testing of pregnant women and HBIG may not always be feasible or may not always be available, so that in most countries, the most feasible strategy for preventing perinatal hepatitis B transmission will involve giving a birth dose of hepatitis B to all infants. Take note, birth dose. So that the primary hepatitis B vaccine series nowadays no longer consists of just 3, but 4, at least 4 doses. That includes a birth dose, which ideally should be given within 24 hours, so 12 to 24 hours. And we are in the era of combination vaccine, kaya lang nagkakaubusan. So that subsequent doses of hepatitis B are now even being given as combination vaccine. So all birth doses should be monovalent, but subsequent doses can be monovalent or standalone hepatitis B vaccine or combination vaccine. So that in 2010, remember, DOH, I went fast. DOH released the first combination vaccine containing hepatitis B. I understand it was in Western Visayas, was it right? But thereafter, the vaccine has been made available all over the Philippines. Is it available in the local health centers where you are? Okay. And about that time, we were also provided with a combination vaccine, a hexavalent vaccine, containing hepatitis B. Okay? Kaya lang, ubus na. So what's the importance of giving a birth dose of hepatitis B vaccine? A birth dose of hepatitis B vaccine, even without hepatitis B immunoglobulin, is considered a safety net to prevent perinatal transmission among infants born to HBs antigen-positive mothers who may not be identified. Diba that still happens, especially those women who don't go for routine checkup. When they give birth, they do not know if they are infected or not. And this will also, giving a birth dose will also provide early protection to infants at risk for infection after the perinatal period. So, I'm sharing to you this very important article that was authored by Dr. Bravo and Dr. Gatchalian, published in 2009, because back then they realized the need for a birth dose, and so they authored a very important article looking at priorities and challenge for hepatitis B control in the Philippines and the importance of a vaccine dose at birth. And these authors concluded that back then, the progress in hepatitis B control in the Philippines has been slow, erratic, and to date inadequate, compounded by a high proportion of births not attended by trained professionals and inadequate immunization coverage. But of course we know, but since then, there have been welcome changes in policy. Okay, so that starting with this, when hepatitis B was first introduced in the Philippines through the API program. Back then, a birth dose was only given to newborns of women with hepatitis B. Since then on, there have been a lot of AOs and Republic Acts, all implementing a birth dose. So it started with this very important AO, okay, implementing a vaccine dose. I think this was during the time of Dr. Duque, followed by the Unang Yakap, and then there was this Mandatory Infants and Children Health Immunization Act of 2011, where again, it was implementing a birth dose of hepatitis B vaccine, and of course, we also have PhilHealth benefit for mother and child, where first dose of Hep B vaccine is included in the newborn package. So, good that as of now, we know that the birth dose for Hep B is in place. So what are the recommended schedules for Hep B vaccination? So there are 2. So one is the CDC widely spaced interval, where the first 2 doses are given at least 4 weeks apart, and the last dose should be when at least 6 months old. So this schedule was found to induce good antibody response, and longer interval between the last 2 doses result in higher final antibody titer or longer duration of protective antibody. And this principle was this policy was based on this study done by Jilk, very old one, which luckily I was able to download from the internet. So these authors look at the immune responses to 3 doses of hepatitis B vaccine using different schedules, 012, 016, and 0112. So what do you notice? The first 2 doses were all given the same 4 weeks apart, but the 3rd dose was given at different times. So the first group had the 3rd dose on the 3rd month. On the 2nd month, so 012. The second group had the 3rd dose on the 6th month, and the 3rd group had the 3rd dose at 12 months. What did they do next? They checked the anti-HBs levels 1 month after the 3rd dose. So what did they see? So this is the protective level, 10 MIU per ml. So 1 month after, so they noticed that the level of anti-HBs all were higher. But so this was on the first group. This was the anti-HBs level where the 3rd group was given at 6 months, and this one given on the 12 month. What did they find out? What do you notice? The final antibody titer for those patients where the 3rd dose was delayed were definitely higher. Okay? So this made the authors conclude that increasing interval between dose 1 and dose 2 has little effect on final antibody titer, but longer interval between dose 2 and 3 results to a higher antibody titer and longer persistence of anti-HBs. That's the reason why, if you read the annotations on hepatitis B in our immunization schedule, it is mentioned there that the final dose should be administered not earlier than age 24 weeks, and another dose is needed if the last dose was given at age less than 24 weeks. However, WHO has another schedule. So this is the minimal interval, 0, 6, 10, 14 weeks, with the doses just 4 weeks apart. This has been found out to induce good antibody response with lower final antibody titer. And this is what WHO prefers for rapid protection and for better compliance. Okay, so what about long-term protection for schedule with shorter intervals? The data is limited, but alternative schedules often are not feasible. Anyway, according to Plotkin, concerns about long-term protection are of less practical significance in countries of high endemicity where most hepatitis B infections are acquired in childhood, early childhood. So I made this slide to show you that vaccination schedule for hepatitis B is very flexible in the Philippines. Just take note that a birth dose, whichever schedule you use, a birth dose should be given using a monovalent vaccine. Okay, so when the hexavalent was not yet available, we used to give a 5-in-1, the pentavalent plus a standalone hepatitis B. But then, when the hexavalent vaccine became available, those of us in private practice have been using it. But the problem for now is its unavailability. But Dr. Chay Aguirre gave us recommendations on how to go about it for now that these combination vaccines are not available. So next question, if there is an interruption between doses of hepatitis V vaccine, does the vaccine series need to be restarted? Of course, you know the answer, it's no. Just like what Dr. Bermal said earlier that no, the series, if there are interruptions, the series does not need to be restarted. So you go ahead to give the remaining doses at least 4 weeks apart, according to WHO. But CDC has a slightly different recommendation because for CDC, the minimum interval between dose 1 and 2 will be 4 weeks. But the minimum interval between dose 2 and 3, if you give a 3-dose series, or dose 3 and 4, if you happen to give a 4-dose series, should be at least 8 weeks. And take note, the minimum age for the final, that may be 3rd or 4th dose of Hep B, should be 24 weeks or 6 months. So next, how can perinatal transmission be prevented in infants born to HBs antigen mothers? So again, I summarized the recommendations in this slide. So we know that if from the start, the baby is born to an HBs antigen positive mom, okay, it's very important to give both, ideally, hepatitis B vaccine plus hepatitis B immunoglobulin should be given or should be administered to the baby, possibly within 12 hours of birth. But if hepatitis B immunoglobulin is not immediately available, pwede mong ihabol, no? But not later than 7 days. What about to babies whose mother's HBs antigen status is unknown? So, for term babies, hepatitis B vaccine should be given. A birth dose should be given, okay, preferably within 12 hours, and determine the maternal HBs antigen status, because if positive, then hepatitis B immunoglobulin should be given as soon as possible, and again, not later than 7 days. But for low birth weights, because hepatitis B vaccination has been found out to be less immunogenic, these babies should be protected with both the vaccine and hepatitis B immunoglobulin. What about for babies born to mothers who are documented to be HBs antigen negative? So go ahead and give them a birth dose or a vaccine before hospital discharge. But if the baby is low birth weight babies, in a mom who is documented to be HBs antigen negative, the first dose can be postponed at 30 days of chronologic age or at hospital discharge if discharge occurs before 30 days old. And should the first dose in these babies be given at 30 days, then that can be counted as a 3-dose primary series. But after birth, please remember to complete the 3 to 4 dose vaccine series, starting at 1 to 2 months old, whether as monovalent vaccine or combination vaccine. So take note that for low birth weights, the birth dose is not counted, as immune response is less reliable, so that this group of babies will really need 3 additional doses, so that this baby should make sure they have 4 all in all. But what if, for babies born to HBs antigen mothers, hepatitis B vaccine and hepatitis B immunoglobulin should be given preferably within 12 to 24 hours after birth to prevent perinatal transmission. What if hepatitis B immunoglobulin is not available? And this can happen. Why? It's expensive. It's not for free. How much is it? I think it's 1,000 pesos. 1,000 pesos siya, di ba? Or more. And it may not be readily available. Would hepatitis B vaccine alone be protective? So infants born to women who are positive, post-exposure prophylaxis, okay, with hepatitis B vaccine and hepatitis B immunoglobulin administered 12 to 24 hours after birth, followed by completion. Take note, completion of the vaccine series has been demonstrated to be 85 to 95% protective. However, giving of hepatitis B vaccine alone, for as long as it's administered at birth, will also be protective, 70 to 95% protective. Okay, so a birth dose is really, really very important. So make sure that all babies that you see is given a birth dose. So when should post-vaccination serologic testing be done on infants born to HBs antigen positive mothers? So you're supposed to do this. You're supposed to check if immunoprophylaxis you were successful in preventing yeah, if giving of immunoprophylaxis prevented the infection to the baby. Okay, so this is a new recommendation that you're supposed to check for HBs antigen and anti-HBs after completing the series when at age 9 to 12 months. Originally, it used to be 9 to 18 months, or that can be 1 to 2 months after the final dose of the vaccine series, if delayed. Why the revision? The revision was prompted by observational studies showing that, so here is the proportion of infants who responded, okay, and here shows you the months after final vaccine dose. So observational studies show that the proportion of infants with protective levels decrease, okay, with increasing interval from the final vaccine dose. And if that happens, this may result to unnecessary revaccination when serology was obtained later. Okay? However, take note that post-vaccination serology should not be done earlier than 9 months old, as hepatitis B immunoglobulin may still be present, and it should not even be done until at least 4 weeks after the last dose, due to possible transient HB antigen positivity related to the vaccine. So post-vaccination serologic testing is not routine following vaccination of infants, other than those infants born to HBs antigen positive mothers. It's not routine for children, for other healthy children, adolescents, or most adults, but it is recommended 1 to 2 months after the last vaccine dose for the following specific groups. And these are patients on chronic hemodialysis, immunocompromised patients, persons with HIV, sex partners of HBs antigen-positive donors, persons and healthcare personnel who may have contact with blood or body fluids of patients who may be infected with hepatitis B. What will you do if the anti-HBs level of a baby born to an HBs antigen-positive mother 1 month after completing a primary series is less than 10 MIU per ml? So remember, as we said, the seroprotective level that has been established is 10 MIU per ml after completing hepatitis B vaccine series. So you will have to revaccinate with a second series of 3 doses using this schedule and retest 1 to 2 months after completing the second series. So give another series of 3 doses. Yet, what if the baby is still persistently non-responsive? So that means the baby's level is still below 10 after a second 3-dose series. So that's a total of 6 doses. And this may occur in less than 5% of vaccinees. These are the patients you call to be non-responder or hypo-responder. And in this situation, you're supposed to check for HBs antigen in case that the patient may be chronically infected. Okay, but if this person is exposed, then you have to treat with post-exposure prophylaxis. I came across a resident recently sa PCMC, pero nag-graduate na siya. And he said, "Ma'am, I was given an orientation on infection control," and said, "Ma'am, what will I do? I am a hyporesponder." Naka-anim na siya, wala pa rin siyang antibodies. Sabi, "Oh, okay, you have to be careful not to be spreading the virus to the patients. And anytime you get a needle stick injury, let us know." Yeah, because here, there are things you will have to do. Okay, so you definitely will have to check the vaccination and antibody response of the exposed person, particularly if the source is HBs antigen positive. So if the exposed person is unvaccinated, go ahead, and the source is HBs antigen positive, go ahead and give hepatitis immunoglobulin, the dose, it's 0.06 ml per kilo in the IM, and start the vaccine series. But for those previously vaccinated and is a known responder, what does that mean? Perhaps sometime you were able to check the anti-HBs, and then showed that the patient had a previous level that was 10 or more, and then now this time gets exposed, there's no need to give anything. But if it's a known non-responder after 3 doses, then hepatitis immunoglobulin, 1 dose should be given, and initiate revaccination. If a patient is a known non-responder after 6 doses, like the doctor was telling you about, then he needs to be given 2 doses of hepatitis immunoglobulin, 1 month apart. But this is the scenario we often would encounter where the exposed person's antibody response is unknown. What should you do? If there's exposure to HBs antigen positive source, then go ahead and test for anti-HBs, because if the level is adequate, what is 10 or more, no need to treat. But if inadequate, that is the level is below 10, that person needs to be given hepatitis B immunoglobulin and a vaccine booster. Okay, and the same recommendations holds true for exposed persons to sources who are not tested or status unknown, particularly if it's a known high-risk source. So, a very important question. Can a mother who is HBs antigen breastfeed her baby? What's your answer, Joanne? I hid. There's one side I hid because of time constraints. Yes, but there are studies on this. But let me just say that from studies show that, yes, a mother who is HBs antigen positive can breastfeed her baby for as long as the baby is given appropriate immunoprophylaxis and the vaccine series is completed. But the carrier mother should not participate in donating breast milk. I am with 2 government hospitals that have milk bank, PCMC and Quezon City Gen, and I know that it's protocol for any mother who wish to donate her milk they have to be screened for hepatitis B. But breastfeeding mothers with chronic Hep B should also exercise care to prevent bleeding from cracked nipples. Is there a need for a booster after completing their primary series? No. Booster vaccination is not recommended for long-term protection for immunocompetent children and adults who responded to a primary series, especially if the last dose was given at 6 months old and at least 8 weeks interval from the previous dose. Why? What's evidence? The primary 3-dose series supposedly induced protective antibody concentrations, that's 10 IMIU per ml, in more than 95% of healthy infants, children, and adolescents, in 90% of healthy adults. But do you know that after primary hepatitis B immunization, anti-HBs levels rapidly decline? Yes, within the first year and more slowly, so that among child vaccine responders, 15 to 50% of them can have low or undetectable anti-HBs levels 5 to 15 years after, and thus also holds true for adult vaccine responders. However, just like the principle in rabies immunization, while vaccine-induced antibody levels decline in time, majority of immunocompetent children and adults are still protected. Why? Due to immune memory that remains intact for more than 20 years following immunization. And persistence of vaccine-induced immune memory has been demonstrated by, again, an amnestic increase after an additional vaccine dose. So, if you happen to be exposed to Hep B, to the hepatitis B virus, even if you are a responder and even if your anti-HBs levels have already gone down, when you get exposed, this is supposed to result in an amnestic anti-HBs response that will prevent clinically significant hepatitis B infection. Okay, and for all of you who are up to date, last month, there were breaking news that hepatitis B vaccine booster is indeed unnecessary and that protection lasts 30 years. Okay? Hindi na lang more than 20 years. There is data to show that immune protection lasts even more than 30 years. You can take a look this up in the internet. Okay? This was published this was made available just last month. 30 years 30 years protection. But for babies given hepatitis B vaccine using the accelerated schedule or schedule where the last dose was given less than 24 weeks, you may consider giving an additional dose to increase final antibody titer. So when are booster doses of hepatitis B vaccine recommended? Booster doses of hepatitis B vaccine are recommended only for hemodialysis patients, and the need for a booster should be assessed by annual testing for anti-HBs. Take note among our nephrology friends. A booster dose should be administered when the anti-HBs decline to less than 10. And what about for other immunocompromised persons? The need for booster is not determined, but should you check the anti-HBs level and it show that it has declined to less than 10, annual anti-HBs testing should be done and booster doses considered if with ongoing risk for exposure. Okay. Next question. What does a negative anti-HBs serologic response mean if previously vaccinated with at least 3 doses but not tested after vaccination? Di ba? Common yan, di ba? You will have to distinguish from true vaccine failure, wherein the patient is not protected, or response to the initial vaccination series, but with waning of antibody, where that patient is protected. So what do? You can give a challenge dose of hepatitis B vaccine to assess protection. Because after giving a challenge, the level goes up to at least 10 or more, that will be indicative of memory response. But if no response, so that means the anti-HBs level remain below 10, then you have to complete revaccination and retest for anti-HBs. Or give 3 doses. Just go ahead, give 3 additional doses and do anti-HBs testing 1 to 2 months after the 3rd dose. And that is considered more practical. Oh, this is the last. I'm going to the last question. One time, I think last month, I was asking my colleagues in FAU, what do you want? What question will you ask me? And one of them, Judith, said, I don't know if she's here. Oh, ma'am, can you comment about providing a medical certificate for a student, okay, who is HBs antigen reactive? So this is a scenario: a high school graduate who is planning to take up a nursing course consults you because of a lab exam with these results. When you see that patient is both reactive to S antigen and anti-HBC, but non-reactive to anti-HBs. This person is asymptomatic, but is requesting for a medical certificate prior to college entry. Sus, pumayag ako, pero this is one lecture itself. One whole lecture. But anyway, all I can say is chronic hepatitis B in itself should not prohibit the practice of or study of medicine, surgery, dentistry, or other allied health professions. An applicant who is HBs antigen positive should not be declared unfit to enroll or unfit to work and denied enrollment or employment without appropriate medical evaluation and counseling. So, there and then you won't be able to, first you won't be able to provide a medical certificate because you know that person will have to undergo evaluation and counseling. Okay? So, what will you do? There are a lot of things you'll have to do, including determining the status of hepatitis B of the student. So you'll have to go ahead and request for HBe antigen, anti-HBe, and even HBV DNA if they can afford. Of course, you have to repeat HBs antigen and anti-HBs after 6 months and hope that the HBs antigen will disappear and the patient will develop anti-HBs. Because if not, then the patient will be chronically infected. By the way, from my readings, I realized that it's now HBV DNA that's being preferred over HBe antigen, and a threshold of that's considered safe is like 1,000 IU per ml. Kaya lang mahal yan. Anyway, you're also supposed to assess the status of the liver of the patient, and I consulted with my gastroenterology friends, yes, minimum will be to request for ALT and liver ultrasound. And subsequently, you'll also have to, you'll also have to evaluate the student for other risk factors and co-infection. Very important, not to counsel about prevention of HBV transmission. So mahirap pala yung tanong yan. Anyway, you can do the initial workup, but it will be easier to refer to the gastroenterologist, di ba? Anyway, I hope I answered the question. So, key messages. Hepatitis B is highly endemic in the Philippines. Perinatal transmission from an infected mother at birth is the most important mode of spread. Up to 90% of infected infants infected perinatally or in the first year of life will develop chronic hepatitis B without immunoprophylaxis, and vaccination is the best approach to HBV control. So let's continue to do our part in helping control hepatitis B. Thank you.
Thank you, Dr. Banez, for the lecture.